I think there's also an aspect of job satisfaction, that comes into play. And a big part of job satisfaction is feeling like A, you're making a difference, B, that you're getting better, and your own stock is rising as a professional, in your field, that you're actually becoming more valuable. And also just personally, I think being challenged, and having that engagement where you're not just on autopilot. And I think one of the it's hard to have all of those things, when when you're in the same organization, the same location all the time. I know personally for myself, I've changed jobs and changed job titles, a number of times, and a lot more probably than my peers. And I've found, and in my current job, even just tackling new projects, exploring new innovative ideas, those things raise my own personal satisfaction in the job. And um, and I have to think that as our founder talks about how he works in a pretty busy ER, but once a month he typically goes and spends a long weekend, working in a really small rural ER. And he sees that as almost a retreat, or an opportunity to kind of recharge, because he's working in a very different environment, different people, different types of patients, and different problems, and he gets to bring his skills and his knowledge to bear there and really make a difference. And then he comes back with a new perspective as well, and feels like he's able to add more value to his normal job.
I have had that situation before I did the kind of turnaround director thing where I am pretty much located at one site. I did work for groups that had multiple sites, and I'm doing that now. There's very clearly a, a if I work a run of shifts at one place now, and I'm older, so I'm not as I don't have the energy that I did when I was younger. But when you're older a little bit, when you do a long run of shifts at one place, it does tend to push you into the zone of like, all right, here we go again. Particularly if it's the same shift and the place is got this constant flow. You just feel like, oh, you're a cog in a wheel, in a machine. The I mean, I liked personally, and this is, I guess, why one of the reasons I enjoy doing the locums. I like the rural environment, and again, it's back to that whole thing about being well trained, in that I feel comfortable with my skill set, in that I will do things that a rural ED sometimes, is, it's you get exposure to stuff that you're the only guy, and if there's nobody there. When I was a resident, I used to moonlight in a place that only had orthopedic coverage one out of every 3 nights, or 3 days. And so, when we had an orthopedic situation during those cases at the rural place, you either handled it or you had to send the patient, far away to be taken care of. And you have to know your limits. But at that point in that environment, if you could do a fracture reduction and get somebody, aligned pretty well, you gave them, the ability to be able to go see an orthoped. They might have to drive 2 towns over, but at least you gave them what they needed emergently. Those kind of rural skill sets, uh, though I think the rural hospitals, would be better served if they could attract physicians who had those skill sets, rather than saying, somebody who maybe. And I will tell you that the shortcoming in emergency medicine tends to be in the hands-on part of it, uh, and that's in orthopedic care, maybe plastic surgery. Trying to think of something else. You know, procedural stuff that residents in emergency medicine are taught to do. Those things may not be taught to somebody who doesn't have that training, and if they're working in a rural environment, they, I don't know what they do if they run into a situation like that. Tell the patient, well, you got to go to, they transfer them, or they tell the patient, I can't do this. You need to go someplace else, or they bring a rural consultant in to do something that they, could be done by the ER physician. And so that's a skill for the hospital. So you talked about this, working. We were talking, working in a collaborative environment. If you're in a rural area, they got one surgeon, and you got an abscess on the patient's back, and it's big, and it's not small. Little abscess needs to be open. So you got an ER doc who says, well, I'm not comfortable opening that. So surgeon has to come in and do something, and maybe comes in at 10 o'clock at night. It's right, he's supposed to go to bed. He's got a case in the morning. Yeah, he'll come in, I guess, if he's a nice guy, but he doesn't have to come in. So you want to be able to have an ER physician who says, I'm going to open this abscess, I'll drain it, patient's going to do fine. Will you follow it in the morning in your office, or 2 days, whatever it is? And the surgeon says, thank you very much. I don't have to come in. I had a case like this just recently. I'm trying to remember what it was. Um, uh, it was something where it was a hand injury, and I didn't really think that the plastic surgeon needed to come in to see the patient. And when I called him, I said, "Look, I just need you to follow this. I just want to see, do you agree with my judgment on this?" And these days you can shoot pictures of stuff so people can really be alongside you. And he was like, "Yeah, that's a great plan. I don't have to come in. I'll see it in the office." And that's a relatively rural hospital. This guy doesn't live very close, and I don't think he actually even would have come in. So, but the patient gets really good care. They get known that there's a collaborative relationship with a consultant, so they feel like they got really good care. Um, so that's a really successful interaction for a rural hospital. But the key is a well-trained emergency physician.
I told you the story on the phone the other day about a 100,000 annual visit level 1 trauma center that was paying through the nose for locums coverage that we work with, and some of the locums companies they were contracted with were sending them. One example they gave me was a nephrologist who was working in this ED and had the paramedics intubating patients for him because they just weren't trained for that kind of emergency medicine. So it's makes a big difference.
That's an example of bad service on the part of they're not giving somebody whose skill set is knowledgeable. Now I remember what the case was. This was a guy who drilled right through his finger with a screw gun, put a screw into his finger. And so this is typical of rural environments where you have people, salt of the earth, farmers, guys that don't come to emergency departments easily. And when they come in, they don't want to be told, listen, you can't do this anymore. You got a problem. So this guy drilled into his finger with a screw, and then it unscrewed it, but didn't come in, until 24 hours later when it was really starting to bother him. And so it was a judgment call where I thought this wasn't infected and was probably going to do okay, whereas I think some other people would have gone, wow, this is a bad problem. And so we were able to coordinate that. So that kind of judgment, I've been doing this a long time, so there's a lot of years of judgment on top of that. But it is, the relationship and the interaction was very collaborative and very smooth for everybody involved. And so at a rural hospital, you want that. And there are great docs out there doing all kinds of other things, but emergency medicine, you have to be trained to be able to cover everything. Got to deliver a baby in one room and then go into another, put a chest tube in a trauma patient, go intubate a COVID patient. That takes a skill set that you have to be trained for. And so those people, they're highly trained, they deserve to get reimbursed, so for their training and expertise. But I think that the rural hospitals should almost do anything they can to get somebody like that to work at their place.